Okay, so now we are officially being recorded. I would like to welcome you to the fourth episode of Your Life Depends on It, our webinar on behavior change in health. Thank you everyone for coming and being with us today. I'm clearly very excited to be here. It's a topic that I deal with, I can say all the time for maybe 20 years now. And we are living at very exciting times where behavior change has become front and center of health. And this is what we'll be talking about today. The title is maybe redundant, but I just want to emphasize how unredundant it is. Today, we're talking about driving behavior change in health, the need and the way. So first of all, we'll establish that there's a need for that. Not that you all don't know that, but just really to emphasize how big of an issue health behaviors are or unhealthy behaviors are. And then we'll talk about the way out of those unhealthy behaviors. And we have with us truly a wonderful guest, a superstar, if you will, Dr. Julie Downs from Carnegie Mellon University. She doesn't brag, but she should, because she has multiple NSF grants. She has, I'll talk more about her in a minute, just an opportunity for you to blush, Julie, to be continued. I'd like to introduce myself and my background in doing this behavior change in health research and industry work. I started out with a PhD at the Hebrew University, went to Princeton University, where I did a postdoc with Daniel Kahneman, whose book I'm sure you've read, Thinking Fast and Slow, and the new one, Noise, out there. I'm not being paid to promote it. I went back to Israel, where I'm full professor at the Ono Academic College, and they also sponsored the promotion of this webinar today. And thank you so much for the Research Institute. I taught at Wharton for a number of years at the marketing department, an amazing department, and also an amazing opportunity to connect the dots between psychology and decision science that I knew and consumer behavior, which is pivotal to everything we're talking about today. My first consulting gig, and I'll always be grateful for that, was with Johnson & Johnson with chronic disease management, with work that we presented in the UN Special Assembly on non-communicable diseases. We haven't solved non-communicable diseases, in case you wondered, but we tried. I went on to working with multiple pharmaceutical companies, some of which are listed here, with health advertisers like FCB and Intus Solutions. And I've mentored for Microsoft Accelerator. Right now I'm at Ono, and I'm a visiting researcher at the University of Cambridge. So that's the mix of industry and academia, and that's part of my ambition in putting together this webinar and posting it on LinkedIn to industry, to people who sometimes are not exposed to all this beautiful academic knowledge that can really drive change. My upcoming book is Your Life Depends on It, What You Can Do to Make Better Choices About Your Health. This is what Daniel Kahneman said about it. Made me cry. People who expect to stay healthy forever need not read this wonderful book. And he doesn't gush. The rest of us should, with a fine combination of humor, compassion, and vast knowledge. Miron-Shatz offers clear and useful guidance for the hardest decisions of life. Thank you very much, Danny. The reason why I'm promoting this is because the message it brings is about true engagement in health for patients and for doctors, because what I've discovered in the course of writing is that everything that plagues patients and creates a barrier for them from fully participating in their health decisions is also a barrier for physicians. So please talk to me, pre-order the book for your teams, and let's do talks about it and workshops about it and help people make better health and medical decisions. I'm done with self-promotion. So why are we here? We're here because there's a lot of work, and there's a lot of academic work, very small portion of it is mine, and many other wonderful researchers on behavioral knowledge and health knowledge. But what I'm realizing, and what I've realized, and what you all probably know, is that knowledge is great and is out there, but the important thing is to drive behavior and not just knowledge. And I brought some examples to really confront us with the enormity of behavior change. COVID has put an emphasis on behavioral health, public health, and health in general. And we're realizing that COVID-19 related death rates are 10 times higher in countries where more than half of the adult population is classified as overweight. Obviously, there are other things going on there. If you could just mute yourselves, that would be great, even though I really love babies. Sorry, thank you. So being overweight is a health risk in and of itself, and also for COVID, as are other comorbidities. There's also cost associated with it. The estimated annual medical cost of obesity in the US was $147 billion in 2008. It has not diminished since. Medical costs for people who had obesity were $1,429 higher than medical costs for people with healthy weight. This raises a question, and we'll be dancing around this question throughout the webinar, and that is, so who cares? Who pays? Who suffers? I think once we connect morbidity and mortality with health issues, we can live more comfortably with the fact that they come with a price tag, and we are less likely to say, well, it's just the HMOs not wanting to foot the bill, because we know people are suffering. But we will speak more about this later. Alcohol. 2018, more than half of the US adult population drank alcohol in the past 30 days. Okay. But how much alcohol did they drink? About 16% of the adult population reported binge drinking, and 7% reported heavy drinking. So if you ever watch TV or a movie, everybody's drinking all the time. What's wrong with that? Let's see what's wrong with that. During 2011-2015, excessive alcohol use was responsible for an annual average of 95,000 deaths and 2 million years of potential lives lost. What about comorbidities? What about disease? Alcohol does not bode well for any of those. So we talked about nutrition, we talked about drinking, and binge drinking in particular. That is a major risk factor for morbidity and mortality. Cigarettes are a well-known risk factor, and sometimes we talk about people's knowledge. I doubt that there's anyone, I want to say in the Western Hemisphere, in any hemisphere, that doesn't know that cigarettes are bad for you. They're dangerous for you. I'll tell you how dangerous they actually are for you. But cigarette smoking remains the leading cause of preventable disease, disability, and death in the US, accounting for more than 480,000 deaths every year, or about 1 in 5 deaths. You would think, or you might think, that given these statistics, people wouldn't smoke, but you would be blatantly wrong, because people do smoke. Nearly 14 of every 100 US adults aged 14 years or older currently smoked cigarettes in 2019. You could ask, so what? You could say it's their right. Yes, it is, but also more than 16 million Americans live with a smoking-related disease. So these people have a preference, they want to smoke. Do they also want to be sick? I doubt that. Again, we have this gap between knowledge or potential hypothetical knowledge about, oh, cigarettes are bad for you, and actually being ill due to cigarette smoking. Before the webinar started, Inam, one of the participants, said, I'm really curious to learn more about behavioral health, because it's a topic that's relevant to all the patients and actually also to us. So in the spirit of us being on Zoom, I want each of us to raise their pinky and put your pinky down if over the past month you haven't been having enough sleep. Put it down if over the past month you've been having more than what the WHO says you should drink, which is 1 drink a day for a woman, 2 drinks a day for a man. Put your pinky down if you haven't been exercising for 30 minutes a day, at least 5 days a week. Again, WHO recommendations. Put your pinky down if you have been smoking over the past 30 days. And I'm not going to ask you about any other vices. But how many pinkies do we have left? You can unmute yourselves and just say, here I am. And I'm going to put my pinky down because I'm a very poor sleeper. So how many of us have their pinky up? Please share with us if you do.
I do.
Yay. Okay, Tamar.
I didn't put mine up, but I haven't had enough sleep.
Okay. So we have one person. One person.
Nope, me too.
You too. Okay, Alan, that's great. We have two people. That's the
And me
best
too.
proportion. Unbelievable. Thank you. So 3, amazing. That's the best proportion any talk I've ever given. So bravo. Maybe it does help that we're all in the healthcare profession, but how many of us have our pinky down? More than 3. What this means is knowledge about sleep, exercise, smoking, drinking. We all have this knowledge, and yet we don't always act upon it. And this is the question, the conundrum that drives this webinar today. Before introducing our guest, I want to talk about something that probably doesn't plague us personally, but is an issue in the United States with unwanted teenage pregnancies and STDs. So I only have the statistics here about unwanted pregnancies. In 2017, a total of almost 200,000 babies were born to women aged between 15 and 19. That's 18, almost 19 women out of 1,000 in this age group. Numbers have been looking better in 2019, so it's only 16.7 women out of 1,000, but still, this is probably not where these women want to be, or at least not all of them. So again, knowledge about how to prevent pregnancy is fairly prevalent, and yet people get pregnant, women get pregnant, not people, just women so far. What's happening and how can we reverse that trend? To answer this question, I'm giving you another opportunity to blush. I'm so happy and excited to be hosting today Dr. Julie Downs, an associate professor at Carnegie Mellon University with a PhD from Princeton in social psychology. Dr. Downs looks like an ordinary person. She is not. She is a superstar in social and behavioral sciences. She drives behavior change. She has incredible knowledge on various topics in behavior change, which I really appreciate because some people focus and narrow down on one thing, but she looks at it very broadly. She has numerous grants from the NSF, and I put down the logo of the US Department of Health and Human Services because they gave her a grant of $7.4 million to reduce teenage pregnancy and STDs. So with that, Julie, we will go over to you. You did not prepare a presentation because we're chatting today, and that's wonderful. I'm not going to tell everyone where you are. You could tell them if you want. I super appreciate your hopping along. I prepared some questions, and toward the end, we'll also have questions from the audience because I'm sure they'll have a lot to ask. My first question is about one of your recent works, which is psychological predictors of prevention behaviors in COVID. Obviously, everyone knows why COVID matters and why prevention behaviors matter. And I wanted to share something that I thought about the title. So the title says psychological predictors. I think when we say psychological, people think, oh, it's people's personality or whatever, you know, I can't influence that. Everyone is different. But actually what you guys have found and what you labeled as psychological, which is indeed psychological because it's not medical, or as predictors of behaviors like social distancing, masking, hand washing, and just coughing hygiene, were perceived effectiveness of these behaviors, anxiety about COVID, and perceived social norms. And what I thought about that was that it's incredibly fascinating because while it's labeled as psychological, which obviously it is, it's also very malleable to change, I think, into policy change. So I'm just wondering what you thought about that, what you found with that.
Yeah, it's funny because I think what you're probably going from is our grant proposal that we wrote last, I guess February, March of 2020, right at the beginning of the pandemic, where we had these great hopes of changing behaviors with, by moving psychological levers. And I'll just sort of foreshadow some of what we found, which was that there were some psychological barriers that weren't really present as we were writing the proposal, but that sort of reared their ugly heads a few months down the road that really interfered with a lot of what we were doing. So what we started out with was a big nationally representative sample of Americans, looking at trying to identify all of the things that would predict their social distancing behavior, mask behavior. Of course, there weren't vaccines yet, but we did ask a willingness to get a vaccine if it were available. And we found very strong predictors, not so much about severity of COVID, partly because everybody just thought it was severe. And so there wasn't a lot of movement for it to be a big predictor. But the main thing was for any given behavior you could engage in, like washing your hands, staying home, working from home, not traveling, wearing a mask, things like that. The more effective you thought that behavior was, the more likely you were to engage in that behavior. It's pretty straightforward. And our plan was to do this big national sample and then dive in on some of the findings and go with small subsamples of our national panel and try some interventions to help move people along these continua to see if we can get more mask wearing, more distancing, changing behaviors. And one of the things that happened a couple months in is that the landscape sort of shifted from people thinking about risks and benefits and behaviors to people thinking about psychological identities and political identities. And that really stymied us for behavior change because it's not that hard to change people's perceptions of how much of a threat something is or how well something works. If you teach people, we sort of saw this in real time, you teach people how to wear a mask. Remember spring of 2020 where everyone was saying, oh, people don't know how to wear a mask, right? Let's not bother with masks. And then it turns out you can actually teach people how to wear a mask, and that turned out to be a huge benefit in cutting down the risk of the spread of COVID. So that's something that is open to change. But once it became people's political identity, that it was threatening to who they were as people, it became very hard to change behavior, and just sort of focusing on the efficacy of a behavior was not very effective. And one of the things we found, because we did ask, even we had the foresight, even this first survey back in, I think, March, or even we had a pilot survey, maybe even in February, and we asked people how much they supported the policies and actions of then President Trump, and that predicted everything. That predicted everything they did. And so it became really hard to change behavior because it was so grounded in these sort of sacred values. And if you supported the then president, you just were not interested in doing these protective behaviors because I think it felt like a violation of that support, of that political support. And so in the end, we actually did not have a lot of success in changing behaviors. What we did, actually the analysis that we're doing now, because we did collect behavior throughout the last year and a quarter. Now at this point, we're getting ready for our final wave of data collection, is to look at people who did get vaccinated, pardon me, once vaccines became available, and to see what we can predict from, of their actual vaccine behavior based on their beliefs very early on in the pandemic. But after changing, very difficult to change behaviors in other realms, like adolescent sexual behavior is pretty hard to change, eating behavior is pretty hard to change. We have had some successes. It was very frustrating to watch COVID protective behaviors become so politicized and really entrenched in a way that psychological levers were just not that effective. I think you really had to get at that underlying identity. It's pretty hard to work against, a very powerful machine that was sort of tying in those identities with those behaviors. So I think that's an example for us all to learn about the implications of that kind of politicization, that kind of identity manipulation, and how powerful that really is, and how that leaves people vulnerable in a way that our strategies to get behavior change are just not going to be as effective.
No, so I couldn't agree with you more. I saw that even, I think it was February 2021, or even earlier with the Pew Research. They did a survey, and about 30 or close to 30% of the US population said, I would definitely not vaccinate. And around 20% said I would probably not vaccinate. And I think where the government was looking at vaccination trends and projecting vaccination rates, it did not take this into account at all. It was thinking about, well, there's a disease, there's a vaccine, you can protect yourself, let's do it. What are the barriers? Logistics, and clearly these are not the only barriers. You mentioned sacred values, and that's a concept from behavioral economics, from psychology. Could you explain what that means, what those sacred values are? And I think it's fascinating. I couldn't help but thinking about that. COVID was new. COVID just showed up in our lives and we didn't know what to do, and someone told us what to do. But then when it became politicized, we said, oh, I do know what to do because these are my beliefs. Let me get back to those rather than listening to whatever people are telling me. So if you could just do a 60-second tutorial on sacred values.
Yeah, the idea here is that for a lot of our values and beliefs, they are, I mean, maybe this isn't the right word, but sort of negotiable, that you sort of say, you know, if I had more information, let's say I believe it's a good idea to carry an umbrella around. And if I get more information about whether it's going to rain or not rain, that can change my behavior about lugging around a big heavy umbrella because I'm doing some sort of risk benefit or cost benefit analysis. You know, more information is going to shift me one way or the other. I'm sort of open to that. In contrast, what we could call sometimes sacred values are values that are just not open to negotiation. And so obviously things like a religious belief, you know, is going to be a prime example of that, which is sort of the, you know, the origin of the term, that if I have a strong belief in God and you come to me with a lot of arguments for why God doesn't exist, you're probably not going to change my mind, right? Because it's not open to evidence. It's a value that I hold and I'm not going to change it. And politics sometimes sort of adopts that. Identity really adopts that. So politics can influence our identity, religion can influence our identity, cultural background can influence our identity. And then we might hold these values that, you know, information is just not what we're looking for to inform that value. And then if you are the person trying to change behavior, you're trying to change that behavior with information. Like, let me tell you more and more and more about the threat of COVID or the safety of the vaccine or whatever information I'm trying to share. And you're stunned that you're not budging people. The reason you might not be budging people is because they're not taking in this information and doing a cost benefit or risk benefit analysis. They're saying, look, this is COVID is a hoax. You know, this is all part of my identity as, you know, whatever their political or cultural background that sort of underlies that. And if you're going to give me this information and it's in conflict with that identity, I'm going to assume your information is incorrect. It's a conspiracy theory. You're just mistaken. What you say is not important. I'm going to discredit the information because I'm just not open to changing.
Thank you, and for that depressing piece of information, but it's really important. No, it's just really important to know what you're up against. Since we spoke of sacred values, I want to ask you something about ethics. This is the question that comes up a lot, and it first came up to me when I started teaching genetic counselors and talking about how they present information. Now, they come from a perspective where they're taught to be non-directive. Basically, what they're taught is just present the information and people will choose. And then I came along and said, there's no such thing as just present the information. Whichever way you present the information influences how people perceive it, how people feel about it, which is even a stronger driver of behavior than emotions. And there's no objective way. You're influencing them either way. And I want to carry this over to the realm that you work in, which is behavior change. And you have the audacity, if you will, to come and tell people, well, let's look at your, but all with good purposes. Of course, Julie and I are colleagues. I'm not here to bash decision science at all. I'm just saying, do people ever say, well, you are influencing, you are manipulating, who gives you the right to do that? People have their own preferences, et cetera, et cetera. Does that ever come up, and what do you say?
Yeah, I would say that's a tension that we discuss a lot. It's it doesn't come up in the sense that I don't have to field that particular question that often just in my, academic world. I think if I were in a public policy setting, it would be more explicitly, on the table. Where the way it comes up and the way we've, my colleagues and I have historically dealt with it is in sort of the perspective that we take and the goals that we set out. Coming from a decision science perspective, I think I see and we see our goals as being a little bit different from a public health perspective, where, the public health perspective, the goal truly is behavior change. We're trying to get people to vaccinate. We're trying to get people to eat differently. We're trying to get people to quit smoking, et cetera. And our goal is really to try to get people to achieve the outcome that they want to achieve. And so in some level, and often people's own outcome is consistent with a public health outcome, right? People don't want to suffer smoking related diseases. People don't want, adolescents don't want to contract a sexually transmitted infection. So in some areas, it is a little bit different. Adolescent pregnancy may be different if teenagers want to get pregnant. And then what we're helping them get to an outcome that they want, and we're helping them sort of understand the implications of outcomes. But we're not telling them not to have sex. We're telling them, if you want to avoid infection, here are ways of reducing the risk of infection, or here, if you want to have an outcome where you're not having sexual behavior with a certain partner or in a certain situation or at all or at this level or whatever, we're trying to help you get to what you want. And I think where this comes up a lot is in some of the interventions that people tried, like the nudge style interventions, where you're trying to change the environment in such a way that it makes it easier for people to do a behavior that you want them to do, that we public health officials, communication experts want people to do. And in some, more in the UK than the US, there's been a lot of pushback. They're like, oh, this is a nanny state situation where you're trying to control people without telling them. And in many ways, I think the response to that, or at least from my perspective, is that we're all in an environment where there are many things pushing our behavior in many directions. And in the US, certainly, there are a lot of industry influences that are pushing us in many directions, from something as superficial and straightforward as advertising, right? Like you see something advertised and maybe you're more likely to buy it, down multiple levels to food policy of what crops get subsidies, right? So corn gets subsidized. That makes high fructose corn syrup very, very cheap versus free. That leads soda companies, restaurants, to be able to create, high calorie soda so cheaply that they can just upsize it by 10, 20, 30 ounces, and it costs them less than a penny, and they can charge you an extra $1, and so it's a high profit margin. That leads them to sell these giant, sodas. That leads us to, drink 1,000 calorie, soda. So all these influences are happening all around us. And we're just a tiny slice of that, sort of saying, well, let's push back against some of these influences that are not in people's long-term self-interest. I think most people at the end of the day would say, I would like to have not drunk that 64-ounce soda. Maybe when I'm drinking it, I want to drink it, but I want to have not consumed it. And so it is a tension. It's a tension back and forth. But we, psychologists, behavioral scientists, we're often a very small force in one direction, with so many other forces from industry and government and other environmental forces, that I think the ethics of pushing people, if we wanted to open that, we would have to bring a lot of other players, Amazon and a lot of other players into that larger discussion.
No, that's absolutely true. And also what you have in mind is really, and I love what you said, helping people achieve their own goals. So even if they want to have the soda, they also want to be healthy. They also want to maintain a healthy weight, judging by the enormity of the weight loss industry. So I guess I think that for me is the ethical key around helping people achieve what they want to achieve for themselves. There's another research you did. There were so many of them. You've really kept me very busy reading the work, and they're beautiful. And you did one on nutritional choices. You did more than one on let's be honest. You did a ton on nutritional choices. There was one in particular that I liked, where you worked on meal aggregations. So what you did was, instead of having people choose a pack meal, like one package, you had them aggregate. And when they aggregated, they could see in like a traffic light model whether they were in the green zone, orange zone, oops, red zone, and then they could scale back. So basically, you didn't add any information. They already knew the caloric content of the meal, but what you did was you gamified it, you gave them more control, you alerted them to the color coding, and that's incredibly simplified. But let's revisit the concepts of system 1 and system 2. Again, we mentioned Daniel Kahneman. So him, but other people as well had mentioned that, had realized that we use two systems of thinking. One is system 1, which is quick and dirty. It's not all that accurate, but it's very fast. It's emotional. It helps us reach conclusions like, is this good? Is this bad? Do I like this? Do I not like this? The other one is system 2, which is much more elaborate. It requires much more cognitive effort. It takes longer. And you use that to calculate, you use that to really ponder heavier issues and reach larger conclusions, to write papers, et cetera, et cetera. The traffic light model is very much system 1. It's like, boom, you're in orange, you're in red. I mean, you can be a 5-year-old and understand that, which I think is wonderful. It's really wonderful, because obesity trickles down to younger children. So if they understand traffic lights, they understand colors. So if we implement that with them, we have an enormous gain in their health. And that, I think, is what they want, and definitely what their parents want. What you found with this study was that consumers liked it. They enjoyed it. It didn't spoil their experience for them. They reduced the number of calories, and they wanted to get back to the restaurant again. So I think that's a win-win. Perhaps not so much for the restaurant, because they maybe bought for a little bit less. But that was beautiful. So I want to commend you on that, and I want to ask you. You said, you'd mentioned beforehand with the COVID study. You mentioned that you had hoped to change behavior. I'm sure there was the same hope with the nutritional choices, with the traffic light model. To what degree is it implemented? To what degree do you see that all this really beautiful, smart, effective work that you do, and it's not just you, it's an entire field, and sometimes a very frustrated field, which is why I decided to write a book, to just reach out to as many people as possible, because even though thousands of people read your papers, there are 350 million Americans, more than thousands of whom need help. So to what degree is this being implemented across the board?
Yeah, the food work that I've been doing is not coming so much from an intervention perspective as from an understanding the mechanisms perspective. I have other work where we really develop interventions that we can then disseminate very widely and sort of leverage that behavior change over time. One of the things a lot of people are doing this kind of food research, and a lot of people are finding great frustration in trying to change people's eating behavior. One of the things that we try to do, and actually I would say one of the principles that ties a lot of my research together, since I am in a lot of different health domains, behavior domains, really not just health even, is this sort of goal of taking the kind of information that public health officials and other people want people to have, that's often really difficult to use information, and trying to make that information more usable to that end audience. And food is a good example of this, because everybody sort of knows they should eat better, healthier, maybe less, depending on how much they're eating. But it's hard to know. I mean, we can all switch to something, all I eat are salads or something like that, but we know we have to have some sort of balance. And it's very difficult and time consuming and effortful. You sort of mentioned the system 1, system 2, sort of a lot of system 2 effort if you were going to keep a food diary every day and calculate how many calories you have and say, oh, I have 170 calories left for today. I can have, 2 Girl Scout cookies. That's how much I'm allotted. If you want to do that, you can, but that's very effortful. And a lot of the approaches, I think a nutritionist, it would be very expert at interpreting that information, maybe even to the point where a nutritionist could be almost system one in saying how much they have left for the day, but the rest of us really can't.
Yeah.
It's so effortful, and even with the effort, sometimes it's beyond our, numerical capacity, and just how much time we even have. We're trying to live our lives. Maybe we're driving between two jobs and taking the bus and picking up kids and doing all these other things. But the last thing we really have time to do is sit down and do complicated analyses. And this big movement that happened about 10, 12 years ago to put calories on restaurant menus with the hope that this is going to help people make better decisions, I think was a little bit misguided in this. I mean, not that it's not good to have information available. I think it is good. But the belief that that was going to somehow allow this floodgate of behavior change was a little bit short-sighted in terms of expecting people to use this fine, detailed information multiple times a day to aggregate over, meals and snacks, and even within one meal where you have a drink and and something else, that it's just very hard to use that information. And we and many other people played around with different ways of presenting that information. So one way is just to put the numbers on the board, and so people were playing around with that before it became the law. Now, if you go to any chain restaurant, you'll see the numbers on the board. And then people, including us, played around with other ways of presenting that. You could present, a traffic light, and say, if you're going to get a snack, here's a snack like dried apples, that would be a green light, and here's a snack like a Hostess pie, that would be a red light. Some things are a yellow light, and that can kind of give people a little bit of heuristic, tool to identify that dried apples are better than a Hostess pie. But if you are, getting a meal, how do you combine two greens and one red? Like, is that a yellow on average? Does one red light make the whole meal? They're not aggregatable. And so we were sort of motivated by that challenge. There's also a challenge of, what do you call a green light and a red light? Is it a threshold of number of calories? Is it a number of calories per 100 grams? Is it, how do you even do this? Whereas with a meal, it's a little clearer because there's guidelines of how many calories should be in a meal. And with technology changing and practices of how we order food changing, really jump started in the pandemic when we all started ordering food online to, pick up and be delivered and stuff like that. And with restaurants starting to implement kiosks, you can order from a kiosk as opposed to from a cashier, there's an opportunity to give people tailored, interactive, real-time feedback. And so once you have that technological tool, you can use it to do the hard part for them, which is to say, all right, here's a sandwich that's 400 calories, and here's a salad that's 150 calories, or with this dressing it's 300, and here's a cookie, and here's some fries, and here's this, that, here's a water, and here's a Coke. And they can have all the information, and they start putting things together into a meal. We can have this guidance. The way we did this study was it was all online. We did it, sometimes people actually got the meal, and sometimes it's just hypothetical. We have, over and over again, we always get the same results. That as they start putting the meal together, we have a green light. When there's nothing in it, it's a green light because it's 0. They start to put a meal together. And for a lot of people, third to half maybe, they put their meal together, they're still in green light territory, and they just order their meal and they're good. But for a big chunk of people, they're putting their meal together, and that light, which is sort of at the top of the screen, turns from a green light to a yellow light. And then here's what they do. Well, we don't see their faces, but we know what they do because we track all their clicks. And then what they do is that they then take something out of their meal and put something else in instead. And so what we see is that we're basically triggering them with this heuristic, which is sort of a system one, a kind of trigger that says, you need to pay a little more attention because you've just sort of crossed the threshold that's meaningful to you. And so then they are doing things, they'll swap the fries for a salad, they'll swap a Coke for a water, they'll swap something out so that they get their meal back into that green light. And many of them get their meal back into that green light threshold once they cross over. But the people who never get past the green light, they don't do any swapping because what they chose to start with was good enough. And we of course compared it to a lot of things. For example, having all the information there, but in numbers to say, if you got above, I forget now what our thresholds were, but if you get above 800, calories for your meal, that's getting into this, you can give them that number. and they're not responding the same way, even though they have all the same information. They know that the threshold is 800. And even if you aggregate it for them and they see that their meal is 900 calories and they see that the threshold is 800, they're not doing that same reaction as they would people in the other condition where they see the light turn from green to yellow. There's something about that. And we tried a lot of other comparisons, other kinds of symbols and stuff like that. And we really found that things that are intuitive and intuitively matched to the behavior we're trying to do, which is to trigger this sort of, oh, wait, stop, hold on, I need to change, that's what's getting us. And it's all consistent with this system 1, system 2 sort of framing of what's happening.
Yeah, no, for sure. I mean, I've seen a lot of platforms and apps that do that. In fact, both Tamar and Brandon asked if you would like to comment on Noom that has a similar traffic light model. So if you'd like to say something about that, and if other people have questions, you're more than welcome to write them down in the chat.
Yeah, I saw some of those Noom questions pop up. I'm not seeing all the chat, but every once in a while someone pops up. And honestly, what I know about Noom is that they, use psychology as sort of habit formation, but I actually haven't delved into it enough. A lot of people are using traffic lights. We have some publications from early on where we had the traffic lights with snacks. There have been a couple other papers using traffic lights. Other things people have used are like, you'll need to run for however many minutes to burn off the calories in this snack, or things like that. And those things are all just trying to, I think, get people, one of the things we find in a lot of our research is that even when people are using the numbers, even when you just give people numbers, the way people tend to use calorie numbers or whatever numbers you're giving them is not in the way that people are sort of weighing and calculating, but they're using it as a signal. And in fact, just putting numbers on a menu sort of is a signal about dieting. We had one of our studies where we're trying to look at how dieters acted different from non-dieters, but we didn't ask whether they were dieting until they already had done the study. And we found that putting numbers on the menu made more people say that they were dieting. So because that analysis turned out to be kind of flawed. But so one of the things that is happening with all of these studies is that everybody knows that dried apple chips are going to be better for you than a chocolate deep fried frosted pie. Like, that's not news to anybody. But if you clue people in to this idea of, oh, I should probably be thinking about nutrition or health, then that's going to sort of, and again, it's just kind of system 1, activating that that goal, that can move them a little bit, but they're not necessarily saying to themselves, oh, 40 calories is the appropriate number and 400 calories is too much, so much as they're saying, oh, I should choose the healthier thing. We have another study where we put snacks, we had the same snacks, we either listed the calories or didn't list the calories, and we either random ordered them or we put them in ascending or descending order. And one of the things we found, sort of a complicated interaction, but if you put them from lowest to high, people tend to take things at the beginning of the list. And so if you have the healthier things at the top of the list, you're going to get a better outcome. So that's fine. But the other thing we did was flip it. So we had the worst things at the top. And if there were no labels and the worst things were at the top, then you get people choosing the worst, highest calorie options. But the interesting interaction was, if you do that, but you add the calorie information, so it's really obvious to people that the worst things are at the top, then they will run down to the bottom and choose those ones at the bottom. So they're using the information not numerically, but as a cue. And so to talk about Noom, although I don't know how they're using the traffic lights, my guess is that what they're doing is trying to leverage this sort of that psychological kind of clicking in that trigger, which we've seen in a bunch of different settings, that can lead to behavior change.
Right. So that's a great point. I think it boils down to system 1 in the sense that it needs to be simple and emotional. Ideally, if it's both. One of my first gigs was with a company that developed like a control panel. I felt like a pilot when I was looking at it, between the lights and the colors and the numbers. And I was like, this is all wrong. This needs to be much simpler, much more emotional, and also helpful for people over time, which I guess is really a huge challenge for us, because we look for sustainable behavior change. We don't just look at one meal. We look for things to change over time. William wrote in the chat and reminded us that there was a really beautiful study. I can't remember right now who did it. You probably will, Julie, on energy consumption, where they showed you the energy meter inside the house, and you would say, "Oh my God, this is off the charts. What's happening here?" And you would turn off some lights or maybe the AC in the rooms where you're not staying at the moment. And that's just another great example of helping people achieve their own goals, not our goals, their goals of not paying too much money for electricity, by making it salient, making it actionable, making it emotional. Oh my God, it's in the red zone. Because if you just show them a number, they're like, okay, it's a number. I mean, I don't even know what my electricity bill is, shamefully. But if they tell me it's in the red zone, I'll be looking around for redundant electricity that I can turn off. So that's almost always the case. And I guess we're all very human. I think that's what we're learning, is that knowledge is not enough. It needs to be delivered to us in a way that is actionable, in a way that is helpful, that is available to us, and also emotional. And that goes toward anything from energy consumption to alcohol. Where if you remember that you're allowed to have one drink a day, then maybe you'll do that. And you're more likely than if you have some sort of a loose idea of, well, as many as you want, or as long as you feel fine. And likewise with nutritional choices, with a more simplified model. And I'm saying that also having worked with some HMOs on things like fall prevention, etc., which are important all around for the doctors, for the patients, for the HMOs. Everybody wins. And yet you have to bring it up, and you have to remind people, and you have to create the triggers. And all this work really is behavioral work that we're doing. Some of it stays in the lab, some of it stays in our papers, some of it gets implemented, some of it needs to be bridged from wonderful studies in academia to really good, smart, capable, well-intentioned healthcare organizations that are trying to drive and push these behavior changes. I would love to hear more questions if anyone has them. And Julie, if you want to say more, then
yeah, I'm just glancing at the chat. There's some really interesting questions in the chat. One of them is about the sliding scale on the menu. You know, you have a meal and it can have between 600 and 1200 calories in this meal. And so how many calories do people think are the one they're choosing?
right.
And often that range is determined by, if a meal comes with a large drink, not to go back to this, soft drinks is the root of a lot of this, but if you have a water or a diet drink, that's, you'll be at the lower end. And, there's a 400 calorie gap, in some of these, and, so a study I'm working on right now, which is a huge gap in a meal. Like a 600 calorie meal is quite appropriate, or even, you have a little bit of room there, depending on, your age and height and weight, all that kind of stuff. And a 1200 calorie meal is, very different, and a soda and a little side of fries can determine that. I'm sure people have looked at that. I don't know details about where people think they are in that range. We do know from other domains that people tend to think their own personal risk. There's a whole literature on what we call unrealistic optimism, where people think their own personal risk is lower than other people. And you talk to smokers, and they'll say things like, well, I only smoke cigarettes that have a filter on them, so my risk is lower. Like, well, all cigarettes have filters on them pretty much, I don't, they have all these reasons why their own personal risk is lower. And presumably you see the exact same thing in terms of this sort of meal creation. And so I can only imagine that you're going to see some of those same things where you have a range, and restaurants might be happy to provide that, and people think that they're getting fewer calories. Actually, there's another question in here, I don't see it now, but it was about whether there's a risk that people who want, especially maybe lower income people who want to get more bang for their buck, might look at the calorie information and say, oh, how many calories can I get for my dollar? And, and that it's sort of a backfiring risk, that if you put that information up there, are people going to get more calories, choose a higher calorie meal because they get more calories for their dollar? And there's been a lot of written and speculation about that. The data we have so far suggests that people are not actually doing that. That doesn't seem to be something that's happening. And it's not that surprising that that's happening, given that people are having a hard time using the information in the other direction either. Some people had suggested maybe you're not seeing an effect overall because some people are getting fewer calories and some people are getting more. And so it cancels out and you get a null result in the end or something. But when it's been, there's just not evidence that that's going on. So I think we can breathe a little bit of sigh of relief that there's not a huge force of people trying to get more calories for the dollar. But it does all contribute to this phenomenon where you're giving people, there's a whole lot of unusable information and then expecting them to use it, and they're not.
Yeah, for sure. For sure. Tamara asked another question on personality characteristics, and I want to answer that. Looking at it from adherence to medication, which is something that I've been dealing with quite a lot. The one personality characteristic that predicts that, and I think also predicts adherence to lifestyle regimes, is conscientiousness. That's the degree to which you're organized, stay on top of things, and just adhere to rules. And if someone says, take this twice a day, you actually take this twice a day, or have one drink a day, or exercise, or any other type of lifestyle recommendation. And conscientiousness is the one thing that predicts that. And it is hard to breed. But, that actually connects with you pointing to Noom. Noom has a selection bias. People go on Noom. People choose to install Noom. People choose to use it over time in a sustainable manner. I can guess that these people are the more conscientious ones, the ones that are more health conscious and more invested in their health. That's not everybody. And actually, Julie, what Julie, Dr. Downs has been talking to us about are interventions that are for everyone. You go to a restaurant. You don't have to choose the healthy restaurant. You just go to a restaurant, and then someone tries to influence your behavior for the best, and to do that in a sustainable manner. And I think that's really a huge challenge, given that people may or may not have the motivation to engage in that. And the fact that you can move their behavior is really commendable and impressive. And also, going back to the ethical issue, it shows us that it's actually fine to try and influence people in the right nutritional direction. They can stay in the red zone if they like, or not. And if they don't, that tells us that their preference really wasn't to go in the red zone, wasn't to eat something that may not be all that healthy for them. So that's like a little sigh of relief from the behavioral science direction, where we don't want to be a nanny state, but we also don't want to be the state where everyone is overweight and has multiple comorbidities just because it's really bad for them, not just for the state. Again, this duality of state, HMO, people's own health, and ideally, all of these are aligned and all of these work well with one another. It's been really great having you. Let me thank you again for everyone, all of our guests, and in particular, our wonderful speaker, Dr. Julie Downs. This webinar takes place every last Thursday of the month. The next one will be on July 29th. I want to talk about advertising, so feel free to reach out with that. And always to talk to me about your ideas and questions. I'm more than happy to answer. Thank you very much, everyone.
Thank you, Talia. Thank you for having me.
Anytime.
Thank you.
Bye-bye.